Levent Balcı çok güzel bir kongrede ve biz de İstanbul'dan ona bağlanıyoruz. Yanında da çok değerli bilim insanları, konuklarımız var. Çok kısa bahsetmek gerekirse bu kongre standart tedavi yaklaşımlarının dışında bir kongre. Yeni fikirler, değişik teknikler, yeni buluşların ve bu konuda farklılıkların konuşulduğu bir toplantı ve mottosu da meme kanserini bitirmek. Şimdi sevgili Levent ve konukları bize bu meme kanserini bitirmek konusunda Los Angeles'ta nelerden bahsediliyor, onlardan bahsedecek. Tabii Levent, bu arada tebrik etmek istiyorum. Senin de orada sunacağın değişik bir buluşum var. Belki programın sonunda da çok kısa ondan da bahsedersin. Sözü sevgili Levent Balcı'ya veriyorum.
Okay, thank you. Hello, everybody. We are having a broadcast from Los Angeles, and I have very, very fascinating doctors who are working several years, more years for breast cancer, to stop breast cancer. As I said, we are trying to stop breast cancer. And Dr. Stephanie Graff, is the medical advisory of Susan Love Research Foundation, and also she's a medical oncologist. She's a professor of medical oncologist in Brown University in Los Angeles. And the other side, he is Dr. Sheldon Feldman. I think in Turkey now everyone knows him. He's getting, you're a fashion, you know, now in Turkey, everybody knows you. And he is last American Society of Breast Surgeons president, and he is a professor of clinical surgery in Albert Einstein Montefiore Medical Center. So, hello.
Hello, thanks for having us.
Good morning.
Yeah.
Good afternoon.
So, all the people in Istanbul listening, all of us, and some of physicians, some of them are survivors, advocates. They are listening. So I'm going to start with Stephanie. That's right.
Yes.
So Stephanie, a little bit talk about the Bible of Susan Love's breast book. You know, in New York Times, they said the Bible of breast book is the Susan Love's breast book. What about that?
So Dr. Susan Love wrote a guide to breast cancer called the Dr. Susan Love Breast Book. And the New York Times lovingly called it the Bible to breast cancer. And we are getting ready to release the new edition in September of this year. I'm one of the proud authors and co-contributors to the newest edition with Susan. And I think, you know, that it's quite the tome. It's a thick book, but it really covers breast cancer A to Z, from prevention to the pathophysiology of the disease, to the full spectrum of treatment. And it's just rich with Susan's plain language and analogies that I think really kind of helps a patient dive deeply into understanding their disease. And it's celebrated as this tremendous resource. I've read it cover to cover as a medical oncologist, even prior to joining the foundation and meeting Susan for the first time.
Yeah, I know you are helping and writing again and again the Susan Love's book, and you are also the writer of the book. That's right?
Yeah.
So congrats to you with Dr. Love. And the other side, Dr. Sheldon Feldman. What do you think about the Susan Love's book?
Oh, it is the Bible. I mean, for many years, it would be sort of almost like a routine. We'd have boxes and boxes of them. And when patients came in, were newly diagnosed, you know, they would get a book. It was just part of the package. I think now, you know, a little more now, the internet, and, you know, which is a good and a bad thing, because there's a lot of misinformation. When patients go online, they're almost afraid to. So having a really credible reference and source like Susan's book is just, it's extraordinary. And I think it's more important than ever.
Yeah. So hopefully all of us, or the survivors or the physicians, may read that book and speak about the Susan's book when we read all of them. Okay. So the first question I'm going to ask to Dr. Feldman. You know Dr. Linda Larson from CAC Medicine. Talk about the artificial intelligence in breast ultrasounds. So what do you think the artificial intelligence may replace the radiologist or they can only aid the radiologist to detect breast cancer?
No, I think AI is going to be a tremendous boon for diagnosis. I think that, even now, radiologists, they have computer-assisted diagnosis. So there is, second reads. But I think some of the technology that's coming, we saw a presentation yesterday from Dr. Clock as well.
Yeah.
For example, looking at this QT, it's really 4D ultrasound, basically. The ability to interpret all of that data by a human is really not possible. So you really need AI to be able to recreate detailed anatomy, of the breast, and that is the future. There's no doubt. So I think the radiologists are actually happy about this. I don't think they think they're going to lose their jobs. But this is another tool.
Yes.
Just like for us as surgeons, when a new technique or new instrument comes along, if it's not replacing us,
Yes.
it's helping us to do our job better.
Right, like the robot. We are using robots, but they are not the leader of the surgery. We are the leader of surgery, but they're helping us. So I'm going to ask about the also QT imaging from Dr. Clock, quantitative transmission ultrasound. What do you think about this innovation?
Yeah, I think so. Dr. Clock's work is really mapping the ducts in a novel way. It's this ultrasound-based technology, this novel technology that allows us not to use radiation. It doesn't require the compression that women really hate with most of our forms of breast imaging. And all of the early data at this point shows very high sensitivity and specificity. And so I think that we need to continue to explore new directions for breast imaging. The market is very competitive. And so it's a fierce and difficult, fierce and difficult landscape to kind of break into. But I am very optimistic. It's work that Susan's been funding and supporting, as is the 4D ultrasound.
That's right. So Susan Love and her friends were working about the 3D imaging, like maybe 15 years. So we're also working on it. So congrats to your work, to your contribute to this study. So what about young breast cancer, Dr. Zhang from Knight Cancer Institute from Oregon. What do you think about Dr. Feldman? What she did, yesterday, spoke about the time between lost childbirth and diagnosis of breast cancer. Is it possible to use that one as a high risk assessment tool for breast cancer?
Right. Well, I think what she's done is really began to expand our understanding of what we used to call pregnancy-associated breast cancer, which now she's really redefined the term as postpartum breast cancer. So that's extending the timeline from a year or two, either during pregnancy or after pregnancy, to up to 5 to 10 years after, and demonstrating that women who are diagnosed in that window have a worse breast cancer, that's prognostic. So that's really, really important. Now, the one limitation of her study, which she admitted, was that the group of the patients who were studied were from Utah, and they were over 90% Caucasian women. So I think in this meeting, we've already had some discussions with her about expanding her work to a more diverse population with more Latina, Hispanic, and Black women, so that can be further validated. But if it turns out that this continues to be a signal, then that would open the door for really more intense potential surveillance and even a difference in treatment for women who are diagnosed within that window, knowing that their prognosis may be worse beyond the usual tumor markers, TNM staging, its phenotype, et cetera. So that it's really a big deal. And first I've heard it, and really, really very exciting.
It's very logical work. If you think about the hormonal environment of a woman who goes through a pregnancy and the impact on their health, and then the time course that a breast cancer develops. We don't think that breast cancer develops over days or months. We think it develops over years. So the fact that we've previously defined pregnancy-associated breast cancer as breast cancer that happens during pregnancy was actually a relatively narrow definition when you think about the pathophysiology of breast cancer disease development.
Okay, so the other issue, the inflammatory profiles in breast milk and BRCA1/2 mutations, the correlation between breast milk and BRCA1 mutations. in terms of the inflammatory profiles. So what do you think about the achievement?
Yeah, I think that work is also really important. We know that BRCA1 and BRCA2 have variable gene penetrance, so they affect different families, different patients differently. And if we could better predict which patients were at risk to get breast cancer sooner or later, higher risk to get breast cancer over the course of their lifetime, and have something, I don't want to say easy because that really diminishes. I've been a breastfeeding woman before, as easy as human breast milk to sample. That would really help us better understand, or even if we could use that as a research tool to build this larger data set to inform a broad population about the impact of their BRCA1 or BRCA2 specific phenotype would be powerful.
So we have a study with discharged nipple aspiration fluid, actually. So what do you think about the inflammatory profiles may be used as a screening model for breast cancer? Maybe we can ask you and
together. Yeah, no, I think this is something that Dr. Love has been emphasizing, the whole introductory approach to breast cancer for the last 25 years, that we know that, that the breast has ductal fluid, which is in contact with the cells that are destined to become cancer, and looking for biomarkers in that fluid, which can be predictive of risk, will be enormous, so that we can really have personalized risk screening for patients. So looking at, for example, biomarkers in breast milk or in nipple aspirate fluid can have huge impact in terms of identifying women who are at increased risk and intervening, perhaps with preventative approaches before they're diagnosed, or enhance their screening. So this is really, this is the holy grail for so many of us that we've been trying to really pin this down. And I think that presentation specifically gets us a little closer.
Yeah.
And I think we've previously seen, the U.S. cooperative groups have previously reported that interleukin-6 is very predictive and prognostic, and this just continues to build on that work. Dr. Love has also been funding looking at the microbiome, which I'm sure is one of your questions coming up, which is another way that our body responds to inflammatory pathways. Of course, we're now using immunotherapy in the treatment of triple-negative breast cancer, maybe other breast cancers soon. And so just thinking about the complex metabolome, microbiome, immunophenotype of the breast and each individual woman is going to be really important.
Yes, that's right. So, Dr. Feldman.
Levent'ciğim, hello.
Yes.
Sorry. Şimdi sizin sohbetlerinizi tabii çok keyifle dinliyoruz ama arada da bana gelen mesajlarda bir ara verip azıcık açıklama istiyorlar. Özellikle bu self-reading portable ultrasound daha önceki projeydi galiba. Ben de çok hoşuma gitti ve çok ilginçti. Ama son birkaç proje bunlar yeni olanlar. Sen bize araya girip kısa bir özette yapar mısın acaba?
Evet. En sonda yapmayı planlıyorum. O yüzden burası amfiteyatr olduğu için en sonda yapacağım.
Tamam.
So the other issue is nipple margin. So Dr. Feldman, your study, and Sophie Lin, your colleague, doing a very, very valuable study. So is it important to remove nipple wart during lumpectomy, or is it important to remove if we have a suspicion in that anterior margin of the surgical?
Yeah, so this work, is really part of our goal to do better surgery for patients and to limit the situation where patients have a lumpectomy for breast cancer and have to have a second surgery because the margins are not clean. And I think there's more and more data emerging that breast cancer tends to migrate through the ductal system towards the nipple. So this was really a very simple retrospective analysis of our patients who had to have second surgeries, looking at which margins were the ones that were most likely to be involved. And it turns out that the nipple margin is the most likely, which sort of lines up, with what we've thought. So that would affect our technique of doing surgery, that we could really orient the lumpectomy to include enough nipple tissue that potentially would reduce the re-excision rates. So we'll be looking at this prospectively. So it's a relatively low-tech, low-cost surgical technique that might have really significant impact for patients. And that's why we're excited about it.
I think it's going to be a big achievement when you have the result of the study. We're going to aware of the nipple wart margin.
Yeah, the prospective study will be important.
Yeah. So I'm going to ask you the vaccine trial. So this is very important. Maybe we are going to use a vaccine for breast cancer in the future. So we have some data here.
Yeah.
What do you think about?
So the NIH presented some data looking at some of the vaccines in development. They're all very early. Honestly, it's very exciting to think that someday we may get to have a vaccine that could prevent breast cancer. There's lots of limitations. There's limitations in recruiting patients to those trials. There's limitations in even just modeling the trial design to have a high enough risk group of people that you can detect a benefit. And so at this point, they're largely doing studies that are trying to detect evidence of immune response to the vaccine in the first place. But the early data is really promising. And so I'm hopeful that we'll continue to move forward. The NIH, one of the big announcements was that they're going to be hosting a patient summit to try to get feedback from patient advocates about what patient advocates would sort of need or be interested in order to participate in vaccine trials moving forward. So if you're interested, reach out and we can help get you connected.
Yes. So we have a trial. Activity in breast cancer patients who are suffering from pathological nipple discharge. So what do you think about the Gardasil vaccine might affect those breast cancer patients, and we may have low prevalence because of the Gardasil in breast.
Well,
what do you think about this?
We're very hopeful. I mean, I think Dr. Balcı has published, and a group from Brazil has published. It makes sense when we look at the etiology, head, neck, and HPV established. And we look at papillomas in the breast as a precursor to cancer. So I think, as Dr. Balcı has looked at the phenotypes of HPV in breast cancer patients, and that they line up very much with phenotype in nipple aspic fluid, that this is really emerging. I mean, it's early work, but wouldn't it be fantastic if 5 years from now we learn that the vaccinations that young women have been getting to prevent HPV has also prevented them from getting breast cancer? It would be, dancing on the table, right? That turned out to be true, and it could turn out to be true. I think it's feasible.
Yep. So the last questions. Do you believe that are we going to stop breast cancer before it's visible on mammography, ultrasound, or anything?
I sure hope so. I think that it's going to be incremental. I think that unfortunately breast cancer is a dozen different diseases. It's not one disease. And so I think that it's likely we'll stop one type before we stop another type, but every step we get closer is going to continue to inform how we then stop the next step. And the research we've seen today or yesterday that we'll see today is foundational for moving us there.
Hopefully.
I'm really proud of the work the Dr. Susan Love Foundation does to help us end this disease. So
what's your opinion?
Yeah, no, I think that incrementally we're getting closer and closer. This idea of the cure coming, it's not that, because it's multiple different diseases. But as we learn more and as we have better strategies, we certainly are taming breast cancer. And I think maybe like COVID, COVID's going to be around, but we're going to live with it and not die from it and not affect our quality of life. So for women and men who are diagnosed with breast cancer, if it becomes like that it's, you've got breast cancer, but this is something you need to do to prevent it from taking over you, then that'll be a huge success. And I think we'll get there.
The last question, what about the MRI versus mastectomy in patients who has BRCA1 mutation? So is the MRI is a screening method, can be a screening method, or we need to upgrade a screening method for those patients?
I've always felt that for patients with BRCA1 or BRCA2 mutations, it's really about shared decision-making. The decision to do a prophylactic bilateral mastectomy is deeply personal. It is dependent on the time in your life, your decision around things like breastfeeding, your body image, your individualized cancer risk, your family experience. And so, sitting down and having a one-to-one conversation with your physician, your genetic counselor, is really how those decisions should be made. And luckily we have amazing resources like breast MRI and, hopefully someday QT and 4D ultrasound and a million other technologies we've been learning about. So maybe someday we can get to, and vaccines, a million other things that we won't need to do the dramatic surgery step. But in the meantime, I'm still a proponent for shared decision-making.
Right. No, I agree. But I do think, I have to say, every time I do a prophylactic mastectomy bilateral, I feel like, what are we doing? I mean, history is not going to judge us well. That, in 2023, we were preventing cancer by removing body parts. And
but don't forget flats. No, don't forget flats.
Yeah, well, regardless, I mean, I just think it's a flawed concept. And I think history will judge us like what we're in the dark ages. But I think we're going to move beyond it. And I think certainly high-risk screening, particularly with Dr. Clark's QT ultrasound, that can be done more frequently. Yes. And I think patients can be surveilled. And if they develop breast cancer,
so
it can be identified early.
Yeah, thank you very much for your attention to this conference. Survivors, doctors, all of the people are very happy to see you here. And they are trying to understand how we're going to stop breast cancer. This is going to be a link from Los Angeles to Istanbul. The last words for survivors and advocates for breast cancer survivors. What do you say? What do you want to say?
Oh, keep raising your voice. It's so powerful and important. I'm so glad you're here and on our team.
Same. We have to work together. And I want to shout out to Dr. Balcı, who's come all the way from Istanbul to be part of this group. His tremendous energy, passion, he's a rock star. So thank you, Dr. Balcı, for doing this, being here, and all of your creative work.
It's my pleasure. Thank you very much. Yeah. Thank you. Thank you.
Thank you.
Yep.
Thank you. Thank you so much.
Yes.
Thank you.
Bye.
My hands. Okay. So, yes, I need to go. And here, Susan, now I'm going to speak about. Wait.
Okay.
So this is a theater. So I need to go from here. Şimdi ben
Suzan'la kongreye gelebildi mi? Kongreye gelebildi mi? Sağlığı iyi mi?
Susan şu an kongrede ama kendisine konuşma izni yok. O yüzden konuşamıyoruz. Yani konuşmuyor.
Ama sağlığı fena değil.
Yani, aynen. Daha iyi şu an. Şimdi ben başka bir yere geldim. Toplantımız devam ediyor şimdi. Şimdi bu tabii ki extraordinary bir toplantı ve birçok şeyin değişebileceği toplantılardan biri.
Biraz böyle yeni buluşlara daha yer verip bunlarla ilgili araştırma fonları oluşturmak ve standartların dışında hem tanı hem tedavide neler yapılabilirle ilgili. Hatta pek çok tamamlanan projeleri de çok başarılı projeleri var.
Kesinlikle.
Şöyle. Sen ultrasondan başlayarak yapar mısın? Bu kongrede neler vardı? Hatta programda bayağı ilginç başlıklar var.
Şimdi artificial intelligence tabii ki radyolog arkadaşlarımız biraz daha bu konuda deneyimliler. Ama burada biliyorsunuz meme cerrahları da ultrason kullanarak hastalarını görebiliyorlar. Dolayısıyla breast ultrasonla alakalı birçok deneyimleri var. Ama artificial intelligence'ın yani yapay zekanın ileride radyologların yerini alabilir mi diye sordum. Onlar da tıpkı benim düşündüğüm gibi asla onların yerini alamayacağını ama inanılmaz bir şekilde doktorlara, radyologlara yardım edebileceğini düşündüler. QT imaging diye bir yeni bir imaging sistem var. Aslında yeni değil, 2018'de patent alınan Quantitative Transmission Ultrasound, QT ultrasound diye geçiyor. Ben bunun görüntülerini izledim. Kontrast vermeden, MR kontrastı vermeden ultrason yani sound'la neredeyse MR'ın göstermediği kalsifikasyonları gösterecek bir tetkik olduğunu düşünüyorum. Araştırmalara devam ediyor. 510K device exemption almış, FDA onayı almak üzere diyebilirim. Belki de bu ilerleyen zamanlarda bu QT ultrasound'un, yani ultrasonun kullanımı dünyada artabilir. Çünkü kontrast madde kullanmıyorsunuz. Çok genç meme kanserleri üzerine çalışıyorlar. Daha çok bununla alakalı literatüre baktım. Bu çalışmaların daha fazla olduğunu görüyoruz. O da şöyle bir şey söylüyor. High risk tool, yani yüksek riski algılayabilmek için, yani bir hastada kanser riskinin olup olmadığını anlayabileceğimiz bazı özellikler var. Mesela erken menarş, geç menopoz gibi diyoruz. Ailesinde meme kanseri var diyoruz. Bununla alakalı çocuğunu yaptığı doğum zamanıyla meme kanserinin diagnoz oldu. Yani tanılandığı meme kanseri riskini değiştirebiliyormuş. Bunu bulmuşlar. Bununla alakalı belki Türkiye'de de bir çalışma yapma ihtimalimiz var. Prevalans çalışması. O yüzden şimdi diğer insanlar da geldiği için ben buradan devamlı rahatsız etmemişim, bu tarafa kaçıyorum. Onlar da toplantıya geliyorlar çünkü. Bir de nipple wart margin, Dr. Feldman çalışmalarından biri. Biliyorsunuz normal bir meme anatomisi huni şeklindedir. Yuvarlak şekilde değildir. Biz round olarak, yani yuvarlak olarak lumpektomi kitleye çıkarıyoruz. Bu Dr. Feldman diyor ki bu çalışmada, yuvarlak olarak yaptığımız çalışmada çıkardığımız hastalarda meme başına yakın taraflarda daha çok şey görüyoruz. Cerrahi sınır pozitifliği görüyoruz. Dolayısıyla meme başına yakın tarafı biraz daha edip çıkarmanın mantıklı olduğunu düşünüyoruz diye bu çalışmayı devam ediyorlar. Önemli bir çalışma. Bir de inflammatory, bu meme sütünde inflammatory profiles, yani inflamatuar hücrelere bakıyorlar. Burada BRCA mutation carrier'lar, yani BRCA mutasyonuna sahip olan taşıyıcılar daha immünolojik olduğunu hani tespit etmişler ve OPG ve rank diye bir şey var. Bunun için Donasunab diye bir ilaç kullanıyoruz. Bu ilaçla alakalı çalışmaları devam ettirmişler. OPG level'ın meme sütündeki level'ıyla risk of breast cancer arasında, OPG level'la meme kanseri arasında negatif bir ilişki olduğunu saptamışlar. Bununla alakalı bir çalışma vardı. Çok güzel bir çalışmaydı. Bir de aslında soracaktım ama omega 3, İtalya'dan bir arkadaşımız vardı. Omega 3 balık yağı gibi bu tarz şeyleri diyette kullanmak, supplementten bahsetmiyorum sadece. Diyet olarak Akdeniz diyeti yapmanın gerçekten meme kanserini durdurabileceğiyle alakalı bir toplantı oldu. Bir de çok önemli bir şey bence meme kanseri aşısı.
Evet,
ve
aşı
bu çok,
çalışmalarını ben de çok merak ettim.
Çok önemli bir şey ve şu an yaklaşık 15 kişi prospektif randomized olarak ikiye bölünerek insanda Amerika'da aşı çalışmaları yapılmaya başlanmış. Bununla alakalı aşılar, Neovac gibi birçok bununla alakalı datalar ilerleyen zamanlarda elimizde olacak. Benim genel olarak söyleyebileceğim kongrenin ilk günü bu. Benim sunumumsa bundan sonra yaklaşık 2 saat sonra olacak. Ben de hastalara şöyle bir bizim Türkiye'den çalışmamızı söylemek istiyorum. Meme başından normalde her hastanın 1 cc, 2 cc akıntısı olur. Ama biz bunu görmeyiz. Biz acaba bir şey yaparak bu akıntıyı arttırabilir miyiz dedik. Burundan bir hormon veriyoruz. Yaklaşık 20-30 dakika sonra bu hormon verdiğimiz hormonun etkisiyle hastada meme başını uyardığımızda oradan meme başından bir sıvı alabiliyoruz. O sıvıyı baktığımızda CK19 level'a bakıyoruz. O level'ın çok spesifik olduğunu düşünüyoruz ve ilerleyen zamanlarda meme kanserini aynı gebelik testi gibi mesela bir eczaneye gideceksiniz. Oradan bir kit alacaksınız. Burnunuzda bir şey sıkacaksınız. Yarım saat sonra memenizden bir akıntı olacak ve değdireceksiniz. Bir çizgi meme kanseri değilsiniz, 2 çizgi meme kanserisiniz. Biz de bunu sunuyoruz Türkiye'den. Bizim çalışmamızı bu 2 saat sonra sunacağız. İnşallah Allah utandırmasın diyelim. Güzel işler yapabiliriz.
Kolay gelsin. Aslında çok Susan Love hani hayatını resmen bu foundation'a vermiş ve mottosu da meme kanserinin yok etmek.
Evet.
Başarılı olacak mı dersin? Bu yeni gelişmelerle, teknolojiyle, yapay zekayla yok edebilecek miyiz?
Valla kanser yok edilebilir miyinin cevabını bilen hani adam dünyada nasıl bir yerde olur? Çok zor. Umuyoruz tabii ki. Susan Love bu konuda çok çalışan biri. Herkese grantlar dağıtan biri ve gerçekten yıllarını vermiş biri. Kendisi biraz rahatsız olduğu için zaten toplantımıza katılamadı. Çünkü konuşma yasağı var.
Evet,
çok az konuşabiliyor.
lösemi geçirip
Aynen.
tedavi
AMD, kan
olmuş,
kanseri
evet.
tedavisi olduğu
Kit
halen.
sonrası.
O yüzden kendisi de çok özür diledi bu konuyla alakalı. Ama biz zaten onu burada görüyoruz ve yaptığı işleri çok iyi takip ediyoruz. Ona çok teşekkür ettik. Benim söyleyebileceklerim bu kadar. Buradan şu an için.
Peki, teşekkürler Levent'ciğim. Seni görmek güzeldi. Yeni
Ben
gelişmelerle
teşekkür
takip
ederim.
ediyoruz. İnşallah değişik buluşlarla
Evet.
dönersin. Çok sevgiler.
Çok teşekkür ederim bütün
İyi
doktor
ve keyifli bir
arkadaşlarıma.
kongre diliyorum.
Ben teşekkür ederim. Bütün doktor arkadaşlarımıza, bütün bizi izleyenlere, hastalara, survivorlara ve onlara yardım eden kişilere bizi izledikleri için çok teşekkür ediyoruz. Görüşmek üzere diyorum.
Çok sevgiler. Keyifli kongreler, başarılar
Teşekkürler,
diliyoruz.
sağ olun.